I'm Dr. Jonathan Salo. I'm a GI cancer surgeon in Charlotte, North Carolina. These videos are designed to educate you about cancer and its treatment and help you and your cancer care team to make the right decisions for you. Of course, there's no substitute for the expert opinions of your cancer care team. The topic of this video is early stage cancer of the esophagus and stomach. This video applies to tumors of the esophagus and gastroesophageal junction and stomach. The treatment recommended will depend upon the stage. This video concerns early stage tumors, which are T1A. If the term T1A is not familiar to you, this may be a good time to view our video on esophageal cancer diagnosis and staging. The wall of the esophagus consists of multiple layers and is surrounded by fat and lymph node tissue. On the inside is the mucosa. Underneath the mucosa is the submucosa. Outside of the submucosa are two layers of muscle called the muscularis. Esophageal cancer starts within the mucosa and with time can invade deeper into the wall. With time, the cancer can go deeper and invade the submucosa. The cancer can then invade into the muscularis. If not treated, the cancer will then grow all the way through the muscularis. A tumor confined to the mucosa is classified as T1A. A tumor which invades into the submucosa is classified as T1B. A tumor which invades the muscularis is classified as T2. A tumor which grows through the muscularis is classified as T3. Endoscopic resection is a procedure in which a superficial cancer can be removed endoscopically without requiring surgery. This is typically performed for T1A cancers, which just involve the mucosa. The procedure is performed by first injecting fluid underneath the mucosa to lift the tumor off of the underlying layers. A portion of the mucosa is then removed along with the tumor. Endoscopic mucosal resection is a technique where the mucosa is removed with a snare. This is referred to as EMR for endoscopic mucosal resection. Endoscopic submucosal dissection uses an endoscopic knife to cut the mucosa to remove the tumor. This is also referred to as ESD for endoscopic submucosal dissection. In either case, this is how the procedure looks at the end. A disc of tissue has been removed and is sent to the pathologist for examination. This is an example of the pathology specimen in an ideal or favorable case. The tumor is confined to the middle of the specimen. The outer edges or margins are clear of tumor. It is clear that all the tumor has been removed. This is termed a favorable outcome from the procedure. Patients with favorable features after endoscopic resection frequently don't need surgery, but surveillance is important to be certain that there isn't recurrence of the tumor. The tumor extends to the edge of the specimen, suggesting that the tumor may have been cut across during the procedure and that some parts of the tumor may have been left behind. For patients with unfavorable features after endoscopic resection, some may need surgery. If surgery is not done immediately, surveillance with endoscopy, or EGD, is very important to be certain that the tumor has not recurred. It is possible for cancer to recur after endoscopic removal, particularly in cases with an unfavorable pathologic result. After any sort of endoscopic removal of cancer, it is extremely important to monitor the area with regular endoscopy to ensure that all the cancer has been removed and that there is no evidence of regrowth. Surveillance endoscopy is done between 3 months and 1 year after the procedure, depending upon the level of concern for tumor recurrence. A special type of an unfavorable situation is when there is tumor found on the deep side of the specimen. In this situation, there's concern that the procedure has removed the top portion of the tumor, but there is residual cancer left behind. Patients with a positive deep margin are at risk for recurrence on the surface or mucosa, but are also at risk for recurrence in the lymph nodes. The challenge here is that detecting a recurrence in the lymph nodes can be difficult. In most cases, surgery or additional therapy is recommended to patients with a positive deep margin. Going back to the endoscopic resection procedure, an important first step is injection of fluid below the mucosa to lift the cancer off of the underlying layers. Tumors that invade deeper into the layers of the esophagus are not candidates for endoscopic resection because it is not possible to get underneath the cancer and lift the mucosa off of the underlying layers. In summary, endoscopic resection can be used to remove tumors limited to the mucosa layer. These are considered T1A tumors. After endoscopic resection, surveillance with endoscopy is important to make certain that the cancer has been completely removed and to be certain that there is no cancer regrowth. Surgery may be necessary for unfavorable features on pathology, a deep positive margin, or for recurrence after endoscopic resection. We hope you have found this video helpful. Here are some links to some other videos. Feel free to leave a comment or a question, or if you have suggestions for future videos. If you or a family member have had an encounter with esophageal cancer or an experience with endoscopic resection, I would love to hear about your experience, so please take a minute to leave a comment below. We're working to create new videos, so please subscribe to be notified of new videos when we post them.